Welcome back to the podcast, guys. I hate doing this every single time. My name's Adrian. Sarah's not here again because she's on a cabin trip. So I've invited some of my good friendly buddies from PT school. Good wave. Do you guys want to introduce yourselves?
Yeah. Sure. I'll go first. My name is Jaron. Should I look at the camera? Should I look at you?
You can look at it. Doesn't matter. I come
Okay.
up to you.
I'll look at the camera for this one.
Look deep into their eyes.
Yeah. My name is Jaron. I'm a physical therapist. I went to school with Adrian.
Yes,
Originally
sir.
from Seattle. Went to the University of Washington. Let's go Dogs.
Oh my God. You guys
and
suck.
then after school, I went to Columbia for physical therapy school, and I've been in the city since then.
Did you just school drop us?
What do you say again?
No, it's okay.
Okay.
School drop.
You just
No.
school dropped us.
School drop. But really into sports. Grew up playing football, wrestling, track and field. Pick up basketball nowadays. A little bit of everything.
Yes, sir. All
There
right.
you go.
And who are you, Mr.?
Mr. what? You're going to
You
go last
tell me.
name?
You're going to tell
Mr.
me?
Tarr. My name's Andrew. I'm from Orlando, Florida. Similar to these guys, grew up playing a lot of sports, very into just being outside, being on different teams, trying to work out through high school and getting a big curiosity about those types of things. And then I went to UCF in Orlando for my undergrad. Decided to go physical therapy with all of those experiences, and then ended up here at grad school with these guys.
Yes, sir.
Still playing basketball like Jaron. Decided to stay in the city to work, and now we're here doing a podcast with our old buddy Adrian Sang.
Old buddy is crazy. Bro, you said,
You're getting old.
yo, chill.
What are you now, like 22?
26. God damn it. You said that you were playing sports and shit, and then you said you got big, and then you paused, and I was like,
Got big.
he just got big.
Yeah.
I think we can just start off kind of talking about what settings we work in right now, and I guess really importantly, what is like the biggest surprise about working since graduating?
So I work for a company called Physio RX, and we work primarily with active teenagers to older adults, well into their 60s and 70s. Some people have had surgeries. Some people are just having some chronic pain. Others are very active. Others haven't lifted a weight or done anything their entire life. So more of your kind of chronic pain, active population, and we actually work in a hybrid way. So what that means is, sometimes I don't see a client after the first meeting. It's all remote care using an app, and I basically program their rehab and training program. Asynchronously, they carry it out, and we have some like formal and informal check-ins along the way. And then the other side of the coin would be the hybrid part, where they come in once a week, twice a week, once every 3 weeks or 4 weeks. So a lot of creativity there with a plan of care, which is really unique because this is out of network. So we're not limited to the constraints that insurance can place on typical physical therapy practice. So super fun setting for that fact, but also provides its own other unique challenges. So that is the setting I work in. What was the other aspect of the question?
Biggest surprise about working in the field?
Yeah, that's right. Man, I'd say, obviously, you go to school extensively and it's a lot of rote memorization, but just the fact that there's always something you can be learning, and I don't think that that's ever over. I don't think there's ever a place where you're like, okay, I know it all now and I'm ready to be done. So it's like continuing ed continues. And then the other thing I'd say is, in school, it's a very anatomical approach, meaning they kind of teach you how to find out the exact thing that's wrong with someone. And I think that, in at least the setting I practice in, that's not the case or the goal oftentimes. It can be helpful and informative, but it makes sense why school does that, because it is largely tied to a medical campus, and it kind of has to be that way because they're teaching to the licensure exam, right? That's ultimately the goal of PT school, is can you pass the test? So you can be super skeptical of PT school and the curriculum, but I think it does serve its purpose, and overall it was a good experience. And so I think I answered that two things, right? The continuing ed part and then the anatomy part.
Yeah. I think even like to that point, sometimes it's like when we're in school, the way they teach us, it makes it seem like it's like life or death if you can't diagnose like a shoulder impingement versus like rotator cuff tear.
Totally.
But I feel like, like you said, in reality, it's just like a lot of trial and error, a lot of figuring out like what really works. Not everyone responds the same and whatnot. So you get a lot more perspective once you like move out of that academic like setting.
Totally.
Yeah.
Yeah. And if somebody has a rotator cuff tear or a labral tear or a shoulder impingement, there's actually nothing we can do to fix that. And that probably sounds to anyone who doesn't have a background in PT like, well, then what do you exist for? But what I mean is a structure thing, that's a surgeon's job, right?
For
what
sure.
we do is we look at someone's shoulder and it's like, what can you not do? What can you do? What do you want to be able to do? And how we bridge that gap. And so it can be helpful to know what the structure is, but I would argue it's not 100% needed, although it is nice when someone has like an MRI when they come in. You can kind of see exactly what it is, but it's not necessarily necessary. So.
For sure. All right, Jaron?
Yeah. So for me, I'm working at a physical therapy clinic called Bespoke Physical Therapy. We have locations in New York, Seattle, and San Diego, actually. And so what really sets us apart, like we're pretty similar to Andrew's, where it's a lot of like one-on-one work. And I think that like really distinguishes us, but we have like a bit of a different spin to it. We don't have quite the hybrid model that Andrew has. So like all the visits, like evaluations, follow-ups are all going to be one-on-one. And we accept out-of-network insurance as well as Medicare. So that like really leads to kind of seeing like a wide range of people. Like the youngest patient I've worked with so far has been 11 years old.
Ooh.
Oldest been 69 years old. So
Wow.
definitely like a really wide range of like goals, activities, and definitely like keeps you on your feet too. Like and even if I see people with similar injuries, like they have different goals, and that makes it really refreshing. I think another thing that sets Bespoke apart is that we have a lot of like objective testing with like force plates, force frames. that kind of
Really?
thing. Yeah, so
That's sick.
that's been cool too. I've been.
Do you guys have?
No, I was talking to our owner the other day about force plates.
Yo, that's sick.
Yeah.
In
So
New
it's
York,
been-
especially.
It's been cool.
They're fun.
Yeah. So there's definitely like a time and place to use it. Like you don't just throw like all of like the testing at everybody, but
For
it's
sure.
nice to like have those tools available. I've even been working on getting trained to do like metabolic testing through this like company called Panoe.
Okay.
So that's been like we'll get into like the running stuff later, but like that's been like a cool spin to like supplementing what I already know about running.
Yeah.
But yeah, like tons of equipment, like full squat rack, weights, and that like really like helps you to like be able to load people properly.
How big is your clinic? What the hell?
We have like 12 to 14 people at my location, but then like we have like a morning shift and afternoon, so it's like a pretty decent size, but we make the most of the space that we do have.
But you have a squat rack and a force plate and meta. Goddamn.
But there's like a lot of equipment we just
Yeah.
like store away, bring out when we
I
need
know,
it. So
but-
yeah, we make the most of it.
I think the fact you have a lot of the services is nice though, because I feel like most
Yeah.
Manhattan clinics are limited by space. Doesn't
Yeah.
Troy have like a indoor like turf?
Yeah,
Yeah.
they seem like they have a lot of
That's
space
cool.
over there. How many treatment tables do you guys have like on your floor?
We have 8 treatment rooms, and then one of them's like a recovery room.
8?
Yeah.
Oh, wow,
Yeah, so
okay.
we definitely
Treatment
have
rooms?
Treatment rooms, yeah. And
Damn.
on top of like the space that we have, so we like definitely have like the space. Like it's nice, 'cause I can like, get people jumping.
Yeah.
You do like a little bit of like shadowing and stuff. Like I
Yeah,
was
yeah,
doing
yeah.
that, working on that with like a basketball player the other day.
Oh shit. That's
Maybe
nice.
feel really out of shape, but you know, it's
That's
all good.
nice.
If any PTs listen to this that don't work or practice in New York, they're gonna be like, "What are you guys talking about?" 'Cause it's just like anything here is space. You
Yeah.
know?
Bro, I know.
It's like a whole
literally.
other layer to working in fitness or physical therapy.
I
It's just
know.
space. So yeah, it sounds like you guys have a
Yeah.
lot. It's nice.
And-
You have to answer the second part.
Yeah. So
No, go for it.
who's the host here? You or him?
Me,
I don't
taking
know. This
over.
is a collective group effort.
All right.
Yeah, I'm the captain now.
Hell yeah.
I'm physical therapy now.
Yeah, that's the biggest surprise that you aren't physical therapy.
Yeah. I'd say that like one big surprise for me is like how quickly the time has gone. Like I started at my
Oh.
clinic like late September, and it really has flown by. Like we actually have a student right now from Colombia, and he just passed like the 4-week mark out of 9 for his rotation.
I was a terminal A.
Yeah, for terminal A, and it like felt like it just went by like just like that. Whereas like now, like when you're working at a place, like as opposed to doing like 9 weeks and then like not seeing your patient again, like I've gotten to see like a ton of progress and like see people like through like the continuum of like it's painful to like get up from like the subway seats
For sure.
to like getting back to skiing, and
For
like that
sure.
takes time, you know. Like it's not going to be like an overnight. Like 9 weeks like isn't enough to get back from like debilitating pain to like full activity.
Yeah.
So that's been like a really pleasant surprise of like getting to like build those relationships and like see people hit their goals, because you
Yeah.
don't always get that with like those rotations. Like
Yeah.
the rotations serve the purpose of like getting some real life experience, like hands-on experience, but it's definitely much different when you're like in
Mhm.
like you're in it and like that's like what you're doing all the
Yeah.
time. So
Yeah.
For sure. So I work in a hospital-based outpatient, meaning we're outpatient clinic attached, part of the hospital. I'm not going to say my hospital name, but
HIPAA.
I think one big thing that We have a lot of space actually. It's like because it's like some old like ortho place, but we like renovated everything. We're getting more renovations, but we don't have any like new equipment. Like there's a photo of the OG crew from like the 1950s or some shit.
Jeez.
The equipment in that photo is still in our clinic.
Oh my god!
Like the exact same leg extension machine, the exact same leg knee flexion machine. It's complete like it's not shit, but it's just like I wish we don't even have a box jump.
Yeah.
We had like a basketball player walk in. I think it was like a high school athlete or something.
Yeah.
He comes in. Do you guys have any box jumps? And we're like, no. And he just like walks straight out.
Hey, what the
I failed
heck?
his barometer test.
I know,
Nice.
but and then I see a lot of. Do you guys see any other patients besides ortho? Like, do you guys ever see neuro? Like, will a Parkinson's patient ever walk into you guys?
I mean, sometimes just foot traffic. We're on a pretty
sure.
busy corner. There's 2 locations.
You
and
have a good location.
It's pretty nice. Yeah, I like. So a little background here. We have a spot, Physio RX in Park Slope, and then in Chelsea, Manhattan.
Wow.
I work at both, half the week out there, half the week here in Manhattan. And the one over in Park Slope, there's a lot of foot traffic. So we do get some walk-ins that are just curious, hey, who are you? What do you do? And every now and then you will talk to someone who's looking for something that maybe belongs with someone else, whether it's like vestibular rehab, which is, usually requires some type of, continuing specialty certification. And so if it's rather benign and they have a history of that, but it's largely been addressed and they have more of the stuff we do, our bread and butter, we'll see people like that, considering their neuro or whatever past they have, other systems that aren't orthopedic. But largely, yeah, if somebody, that's their main concern, we usually will refer out.
Gotcha.
Yeah. What about you? You get
So,
like nerve
so
people?
so far, like for me personally, like I've mostly seen like orthopedic conditions, but like it's definitely not abnormal for like people with like underlying neurological conditions to walk in the clinic. But actually, pretty crazy story. So Andrew and I both used to work at Dodge Fitness Center, the Columbia undergrad campus. Shout out, no, Andrew.
Oh, look
Andrew
at
helped
those
me, Andrew helped me
Dodge
get the job,
Fitness.
so
Yeah.
it was cool.
We operated out of an old racquetball court in the basement of this
Yeah.
place, so there was no
For
sunlight,
real?
no windows.
This is a personal fitness place, right?
Yeah, it was
Yeah.
called a fitness studio, but that's
Jeez,
pretty
that's a disgrace.
No,
yeah.
but it's actually pretty wild though. Like even like as like personal trainers,
Yeah.
like that was like our like role at the time.
Yeah.
Like I saw some people with like pretty like complex like underlying conditions. Like
Yeah.
someone I saw had Ehlers-Danlos, which is like considered like a pediatric condition, but like you're pediatric, you grow up, and then like, you still have the condition, So
Yeah.
someone with Ehlers-Danlos, someone who had Guillain-Barré,
Jeez.
and then someone who
Yeah.
had like multiple sclerosis. So you're like
Jeez.
these things are like much more common than you think, and like
Yeah.
it's definitely not a surprise to like interact with those people. And there's like so much overlap between like each of the like 3 fields of physical therapy or like sub like divisions of PT.
Yeah.
So it's like it really is important to like be like a very like well-rounded clinician and like,
Yeah.
have like an understanding of those things. Yeah.
I even had a client, as again, our roles during grad school at the jobs we had were just personal trainers. We were not licensed physical therapists at this point. And I had a client as a trainer who had, I don't remember the level impacted, but it was spina bifida. And
He was an adult.
yeah,
Jeez.
she was a college student, freshman in college from the neighborhood, went to Columbia. And so, I think the bigger point here is that even if you are, I don't even want to say just a trainer, because there's awesome trainers, personal trainers, strength coaches who are well, educated. They've either gone to college or taken it upon themselves to learn. And you're probably going to see some of these people out there
For
that
sure.
kind of slip through the cracks, and having some understanding of how to just work with them is important. And I don't know that if not for grad school, I would have been super confident in that.
Yeah.
So it's nice, you take your pediatric courses, so you have some type of framework for that, and then you just rush to, Dr. Google and refresh yourself on like big no-nos not to do, and then that's kind of how you can just make informed decisions moving forward. But yeah, it was an interesting job for sure. Yeah.
Jeez. That sounds intense. A little bit.
I mean, that was maybe the 2%.
But also-
most of
Those
the
are
time
very
was normal.
extreme
But
Those-
also, I can
yeah.
imagine to other people who don't have like the DPT training, they're kind of like, "What the heck is this?"
Yeah. And when I was
Jeez.
before grad school, that's how I was. I remember I kind of used to shy away from anybody in any pain.
Yeah.
I used to think people wanted to go into physical therapy. It's like, why would you want to have those challenges? I just want to work with healthy people. It's easy. But yeah, I think it's actually much more intellectually stimulating to have to kind of navigate some challenges. And,
For sure. Yeah.
Yeah.
We're going to move on to PT myths. We're here to clear up some misconceptions about our profession. But hopefully it helps you guys kind of understand more about what we do and our responsibilities as like healthcare providers. So we can just spend as much time as we want on them or as short as we want. But the first one we want to talk about is, are we doctors or not?
It's a good one. Yeah.
Do you guys want to start?
It's in the
start.
name, Doctor of
Yeah, you
Physical
start. Go ahead.
Therapy, you know, so.
Yeah, it's in
and
the name.
depending on, like, state laws, too, like, the majority of states in the U.S., like, are direct access, meaning that, like, you can go see a physical therapist as, like, the first person, you know? There's, like, definitely times where, like, you should go see the doctor and, like, where, like, physical therapists could even, like, refer you to see a doctor.
Mm-hmm.
But, like, you know, lots of times, like, the end result of, like, a doctor's visit ends up being, like, a PT script, you know? So sometimes you can bypass that and just go straight to the PT, depending on, like, insurance and, like, different situations like that. And, like, you may need to go see the doctor. Don't let seeing the doctor, like, be a barrier to, like, getting ahead of, like, your physical therapy. Because, like, lots of times when people, like, wait and, like, prolong it,
Mm-hmm.
it, like, can slow down the rehab process. So, like, try to get in as soon as possible and, like, just get started on the rehab. That's definitely what I'd say regarding that.
For sure.
Totally. Yeah, I couldn't put that better.
I think it's just like the term doctor is thrown around so much.
Yeah.
And typically when we say it, it refers to like an MD. But it's like, as much as like dentists are like they specialize in teeth, like an orthopedic surgeon specializes in like surgery and whatnot, our profession is we specialize in like movement and like knowing how the body works, how like these strength and neuromuscular whatever impacts like our function and whatnot. So that definitely, like, if you have like something that relates to that, like if it's like knee pain, for example, at least we can help you screen for it. And like if it's something worse, we probably know enough. No, not probably. We definitely know enough to like be like, okay, you need imaging, or like even like to your saying, like some states allow like PTs to order imaging, you know. So it's like we can do much more. How do I say this? Than you perceive us to, almost.
Yeah.
Yeah.
Yeah. Your responsibilities and what you're legally allowed to do.
Yeah.
You know, it's at the end of the day, it's a clinical doctorate in physical therapy, and
For sure.
dentists. I can't say 100%, but I'm pretty sure there's two different types of. There's probably gonna be some dentist out there that's this guy's an idiot, but I'm pretty sure it's two different types of clinical doctorates that you can do.
For sure.
There's clinical psychologist. There's a lot of different clinical doctorates out there, and we're one of many. And it used to not be that way. It was a bachelor's degree, it was a master's degree. Now it's a doctorate.
Which is crazy.
And whether you decide to call yourself that or not, formally or informally, with your patients or clients you work with, is up to you. But you know, I don't shy away from it. I think it's something you work really hard for and you spend a lot of time doing. So why not own that and just, yeah. I think there's like this older school of thought, maybe some clinicians who graduated in like the 90s or the early 2000s who may not have that. So they don't actually technically call themselves doctors, and then that can confuse patients. But ultimately, it's kind of semantics. And then the last thought I did have was whenever I refer to someone's MD, their doctor, just to avoid any confusion, I'll try to say physician even.
For sure, yeah.
Because we're not physicians. We're doctors of physical therapy.
Yeah.
And then an MD is more of the physician that you're referring to, just to kind of work on the language with them if they are confused. But I've never run into a point where some patient asks and is confused, like, wait, my doctor? I thought you're a doctor. Like, that's never happened. But yeah.
I think even to that, I think language is so important. I think the public perception might be like healthcare functions as like a hierarchy almost. Like we have the doctors on top and then everyone else is just kind of like the support crew, versus I think we all fulfill a specific function within like the medical field. And that's why there's so many of us. And if like we didn't deserve it, if we didn't need to become a doctorate degree, we wouldn't have, right? At the end of the day. So I think it's like we are properly trained in what we know, and we'll just leave it at that. You know?
I don't know. I don't feel the need to have to convince anybody. I mean,
it's
pretty busy. Like, you know,
my biggest thing is one time I got in an argument with a patient because her doctor told her to use like e-stim and ultrasound as a way to treat her plantar fasciitis, and did not want to do the exercises. And I was like,
That's
well,
tough.
I know.
Yeah.
I was like,
Did the doctor say no exercise, or the patient just didn't want to
the patient didn't want to
Okay.
do it because the doctor had said, oh, these two will like, you should start with
okay.
these two. And I'm like, I don't want to like put e-stim on
yeah.
you.
Well, that's a whole other discussion. Maybe we'll get into this, but like
yeah.
the poor narratives that you hear people come in with from some other, whether it's a doctor, a physician, I should say, another PT, a chiropractor, a body worker, even a massage therapist, you know, they'll say some things to people that we end up working with that you have to really unwind and do that in a slow and kind of steady way so you don't lose their trust.
For sure.
'Cause if you tell someone when they come in, like you're mentioning, I think that's dumb, they're going to walk out the door. But yeah, it definitely creates a obstacle and a challenge, but
For sure.
yeah.
All right. Next thing I want to talk about is kind of the misconception that physical therapy is like medicine, where it's instant. I feel like we have a lot of maybe patients who come back in like a week and like I don't feel any better. What do you guys have to say about that?
Something I often see, and you probably see this too in your setting, is chronic pain. So someone might come in and say they've had lower back pain that's lasted for 10 years on and off. And, I think you have to manage expectations early on. And so I would maybe word this a little differently than I would here with you guys right now. But it's like, what makes someone think if they've had 10 years of back pain that even like 12 weeks is going to completely reverse that? But again, you have to just manage expectations, all about communication. And, it's likely not a simple fix. There's probably not something out of place that you can just put back into place like we're cars. It's probably so many different things that you're going to have to address, what's going on, not just physically, but emotionally, psychologically. 10 years is a long time to just get a quick fix like you would take a pill for, like a headache. And that obviously that's one dramatic example. But in terms of something like I hurt myself this weekend, there was actually a moment where something happened to me and I hurt myself. Now you're talking like a prognosis. You're trying to talk to this person about how long it might take them to get better. And sure, there's certain things we're going to see where you could be more confident in saying 4, 12, 16 weeks. But a lot of the stuff you're seeing in the gray area that is kind of more ambiguous, it's been going on for a long time. You have to speak with conviction and embrace uncertainty and do that with them in a way where you don't like frighten them,
Damn. You're eloquent as fuck.
Thank you.
Sorry.
Doesn't feel like it.
I was admiring. Jaron,
I don't even know that I answered that question.
No. I think, that's good. Jaron?
Yeah. Like, kind of similar to what Andrew was saying, like, it is like a process, and there's like one of the big differences between like taking a pill versus like doing physical therapy. Like the pill might address the symptoms, like it might like reduce that pain. Even just like slapping ice on something, like it's going to take away the pain because it's just like cooling the area.
Reduce the swelling.
It just like kind of decreases the sensation of pain,
For sure.
And like pain science is like a whole nother rabbit hole.
God.
We're not going to go down that rabbit hole quite yet, but even just like reducing the symptoms, that could take like a week or two, Like sometimes people will like be like, oh, I feel better, and just like drop off the schedule. But in order to get like serious strength gains, like that's going to be like much longer, like strength gains to like address like those specific impairments. And one thing that like people don't realize is like the first like 6 to 8 weeks of like strength training and like doing any sort of like practice, that's like more of like coordination improvements and stuff. Like if I start benching, like the first 6 to 8 weeks, I'm just gonna like get better at benching. But then to like really build muscle, that's gonna be like beyond that like 6 to 8 weeks, like 12 plus weeks to like actually like build muscle and to like
For sure.
make your body like a little bit more resilient that way. So it is like it really takes like a longer time to like address those specific impairments. And like when people like ask for like timelines right off the bat, it's a little bit of a challenge because like everyone responds differently to like different interventions, exercises, like hands-on stuff.
Yeah, definitely.
So it really does take a little bit to see like, hey, like what works best for this person? How do I best educate this person? Someone could have like identical injuries, but then respond differently, because they have different training backgrounds, different goals. So it really is like a constantly changing system, and like day to day too. Like sleep is so important. Like your daily activities impact your rehab a lot.
And even to the point you make about strength gains, it's like I think people forget like how much stimulus and constant stimulus you actually need to have the strength gains. It's like my HEPs a lot of times is like 3 sets of 8 with like a red band or yellow band. If you're not progressing, if you're not doing like things to make it harder, like by yourself outside of the 2 sessions that you come with me, because I can't monitor you 24/7. Like part of it is education, like health literacy, right? But it's just like a lot of them just think like if I like, like do my red bands, I should be okay in like 2 weeks. I'm like, that's like step 1 of like 10 of like getting better. But
Totally.
Let's talk about imaging does not equal impairment.
It's a good one.
So
Start there.
I can give a little background on why I want to talk about this. I think a lot of me working in a hospital setting, people are always like, I got my x-rays and they saw this and this is why I feel pain. And then they just become so fixated on like I have, like this ligament's like slightly off. Oh my God, my ankle's like on fire or something like that.
Andrew mentioned earlier with like shoulder pathology is that like if there's like torn ligaments or like a torn labrum, like we're not going to be able to change that. We can't undo like the tearing or the damage that's been done.
Mm-hmm.
What we can change is like the stability of like the joint itself, and there are things that we can change. There have been studies that have showed that like some people who like have like they're very positive on imaging, meaning that they like find a lot of things that are like wrong with like the spine, but then they don't feel anything. And then like the vice versa, like someone will be like in a ton of pain and they won't find anything.
For sure.
So like it's not to diminish like what the person's feeling or to be like, oh, like ignore the x-rays, because like it does give us good insight as to like, hey, like there's something seriously wrong that we need to do,
right?
Or that like a MD would need to do like a surgical intervention or do something else to make it safe to do physical therapy. Whereas like there are times that we can like get pain relief and like change things around the injured structures in order to like get them back doing what they want to be doing.
For sure.
Yeah, I think the only thing I would add, that was awesome, is when you have someone come in, or if you go in and see a physical therapist and they do a physical exam on you and you're worried, right? Should I get imaging? Do I need a surgery, right? You're really worried. If they get a sense that you have what I would call a pathological joint where it just does not feel normal, there's a bunch of yellow, red flags popping up, your antennas are up, your gut is telling you this isn't, whatever I'm seeing and feeling is not normal, then you're going to end up in the right place, because hopefully they refer you to, if it's a neurologist you need to be seeing, or an orthopedist because they actually need to fix something, then ideally, right, you sort of like triage this person's care and get them in the right hands. And I always try to tell people after I've met them, after that first hour, is you do belong in a PT office of some sorts, and this is something you can address with this, or if I didn't feel this way, where should they go, and how do you make that facilitation, right?
For sure.
Assist. We played a lot of basketball through grad school, so I just want to talk about that.
Hell yeah. I'm curious of what you guys think about this. The concept that all PTs are made the same. I guess, like, in your perspective, how much does experience and, like, maybe not education, but just, like, experience and, like, new grad versus, like, older grad, like, how does that play into, like, like, being a good PT, I guess?
Like, I think one thing that's really valuable, regardless of, like, where you went to school, like, what your background is, like, being able to, like, empathize and, like, have an understanding of, like, what your patient does. There's a PT I really admire who works a lot with, like, field hockey, like, women's field hockey players. He never played field hockey, like, and, like, he, like, never, like, did this, but he takes a lot of pride in, like, having, like, done his research and, like, gotten, like, as much information as possible about, like, what the demands and, like, the needs are. So, like, if you're able to put in the work and, like, get an understanding of, like, what your patients need, I think that's, like, what, like, allows you to be, like, a great physical therapist. But I do think there's a lot of value in, like, if someone was a runner, like, prior to being a PT, and then, like, treats runners, they have, like, a really, like, in-depth understanding of, like, what they need. So I wouldn't say it's, like, the end-all be-all. Like, if you were never, like, a runner, you can't treat runners, or, like, if you're never, like, an NFL player, like, you can never treat NFL players. Like, that's just, like, unreasonable, you know?
For sure.
So it's all about, like, having an understanding and, like, being willing to, like, learn about your clientele. I think that, like, sets you apart as a PT.
Yeah. Yeah, I guess the only other thing I would add is if, theoretically you go to school so that just checks the box that you're safe. You're not negligent. You're not going to harm someone. You're not going to kill someone. So if someone actually went through that and they didn't have to retake their clinicals, or they failed a clinical because they were unsafe, and then they passed the licensure exam, and theoretically they're sound to at least just see people and not hurt them. So yours was, I love that answer because it's spot on. It's like if we're allowed to cuss, right?
Yeah.
If you give a shit, you're probably going to be a good PT, and you actually look out for people and you try to make the best decision, the best informed decision you can for them, and putting them first, and not just making decisions off of ego and because you might sound smart, or you're fulfilling some need in you, then you're probably going to be a pretty good PT. And then if you're a person who's looking for PT, the person in front of you at least graduated, I would hope, so that hopefully they don't harm you. All right, and those are kind of the two extremes. He already got the good answer, so I'll give the other end is you're probably safe at the least. But
for sure.
Yeah.
Okay, cool. All right, we're gonna move into our running questions now. So this segment today, I thought it'd be fun to just the three of us talk kind of about like common like running questions, especially we're kind of in the season's getting a little warmer. People are gearing up to train for like half marathons and whatnot. So, and then we actually, I think all three of us see a bunch of like running patients, right? Jaron used to be in this run club in grad school.
Columbia Run Lab.
Columbia Run Club with a professor of ours. So they looked at like gait, like running form, a lot of like analysis and all that stuff. And Andrew, you come from like a CSCS background, so a lot of like the strength training stuff, you're pretty in tune. I mean, you guys both are, but that's why I kind of chose you guys for this podcast. But I think we can start with just like a really, really easy question. How do you guys feel about like, is running an entry sport for someone who doesn't really have much background with like physical activity? And I bring this up because I think it is seen as like an easy entry sport. You just buy a pair of shoes, you have the equipment right outside your window. Just go run and train, train for a marathon, train for a half marathon. I think, yeah, it's easily accessible and it's seen as like a low entry sport.
You hit it on the head. It's very accessible. I find a lot of people that I meet who have never really trained or exercised. And I guess we could start with that too real quick, is exercise and training. Training sounds very hardo. And it's like, oh, you're training. Like, what are you, like LeBron James? You're training. But training just implies there's some type of thing you're tracking or measuring, and there's some end to what you're trying to accomplish. Exercise to me is great, but it's like getting tired, right? And that's kind of the distinguishing thing, because I have people where I'll call it training and they're wondering, like, they work a 9 to 5 and they think, oh, I'm training. But, it basically just implies there's some means to an end and you're actually tracking for that. Where a lot of the fitness classes that exist, Orange Theory Fitness, F45, those things are great, but everyone's kind of showing up and doing the same thing together. And I would call that exercise. And again, that's not a negative thing, right? That's not negative. I'd never knock anybody for going out and doing some of these classes.
Like, fuck them F45 kids.
Yeah, right? The coaches and the programming there is not individualized. So again, it's not inherently dangerous or bad thing, but if you find you have a goal, whether it's to look a certain way or perform a certain way, or you have an injury, then it's worth training, not exercising, because training is going to address how you want to look, how you want to perform, and if you have some type of injury or discomfort you're feeling, training will address those things. Exercise might not. But it could be, you could do some general thing that's not made for you and it might make you feel better. So I would say, being on both sides of the fence there, that exercise is good, right? But training is, it's made for you and you're tracking it. So that was one tangent. What was the original question?
Do you feel like running is like an entry?
Yeah, I don't see why not. Now, if you just start, who did I say earlier? The movie Forrest Gump. Yeah. if you just put on some shoes and run across the country, like, you're probably going to run into some nagging injuries and that won't be desirable. But if you decide to start running and theoretically you progress anything slowly but surely, you're probably going to be pretty good. So I don't see why not.
Yeah. Like, long story short, I'd also say yes, just because of like what you're saying with like accessibility and also like simplicity too. Like, for someone to start playing football, it's a lot hard, like less accessible than like for someone to start running, so like Andrew was saying, like, whatever way you can like get active and like, especially like working on like your like cardiovascular health, that's like a really good indicator of like life expectancy. So definitely it's like a positive thing to work on, like your cardio, like your respiratory system, like your aerobic health, like those are like all really good things. But yeah, like Andrew was saying, like, people often like want to jump straight to the marathon,
right?
But lots of times you gotta like get a couple 5Ks under your belt, do like a 10K, try a couple halves before you like go to that marathon. That's to like get you used to like the process of training, because it really is like a process to like plan like what you're gonna do like leading up to the race and everything, versus just like doing it on a whim. Doesn't get like quite the best results, like health wise and performance wise.
Yeah.
From like a strength aspect and kind of like in our clinical practices, what are some common reasons we see like running injuries?
Yeah. I think continuing on the question we just answered, that's, there's a lot of context we haven't addressed yet, but totally. If you're running and you're not doing any other type of physical activity, that's not, again, inherently dangerous. You could probably have great success, run faster and longer distances without any pain. but you're leaving a lot of gains on the table to be had if you're not doing these other things. So strength training is one huge stone to turn over in terms of your performance. And a lot of runners who, at least in my experience, I'm sure you may agree with this, but you'll meet a lot of runners who only run and they're having these issues. They're not performing. They're not running as fast as they'd like. They might even have some pain. And then suddenly they start strength training, even though they've been kind of against that, most of their adult life. And they start to feel better and run better. And now they love it. And runners have really type A personalities. I find, at least. They got type A. They get really fascinated and addicted with things. So when something works well, I feel like they want to do more of it. So sometimes someone who hated lifting weights, who's a runner, ends up having a lot of great outcomes from starting to just incorporate lifting even once or twice a week. I think people are surprised at how little it actually takes to maintain. They get hooked, and then they want it, like they only want to lift, and you got to kind of have that balance with them. So
For sure.
I think it's important.
I'd say one other missing piece that people don't really consider are just like really simple plyometrics. Lots of times people think like, oh, like I can go from like squatting to running like just like that. But there's like so many other steps in between it, like jumping off 2 legs, jumping off 1 leg, like hopping, skipping. Like there's like a lot of things that like can help you build up to running. And it also just kind of changes the way that like your legs are being exposed to like the force too. Like if you're like, yeah, like all like the landings and everything. Like
For sure.
If all you do is run on like a flat surface, like there'll be some variability, but like you're like loading your legs like the same way all the time. If you add like a lateral jump or like hopping back and forth, side to side, like it does like strengthen your muscles in different ways and just like makes your legs a little bit more resilient. And in one of like a lot of my past clinicals, one of my past clinicals, like my like clinical instructor told me to like track their like foot contacts or just like how many times you're landing. And you can almost like try to like get that to be a comparable to like running for like 10 minutes or something and kind of like have that be like a precursor to running,
Wait,
like
what do you mean? What do you mean track your foot contact?
Like say like I do like 5 box jumps or something, or like depth drops. That's like 5 foot contacts right there. And then say I run like 80 to 90 steps per leg per minute. You can kind of like measure it out to be like, oh, if I need to get to like 200 to 300 foot contacts, like what kind of plyos can I do to like prepare my body for that? Because like when you're running, it's like just like the same thing over and over again. So it's like a lot of like repeated like contact and like landings. So like kind of preparing your body for that. Like if all you're doing is strength training, you're kind of missing a piece with like the plyos and like the landings and all that.
Yeah. I was going to add, yeah. So with, I think the question was just injuries with runners, right?
Right.
So I think setting the table here with some context, it depends too on, does the person just want to be able to, I'll meet someone who's like, I don't even know that I could run across the street if I needed to. So at a human level, running isn't a sport. It's something that our body's hopefully capable to do if you can get there, if you have 2 legs to do it. And so sometimes you'll meet someone on that end of the spectrum where it's like, hey, I'm just so sedentary and detrained. I'm not even confident that I could run and catch a bus. And I actually do have trouble with that. And then you might meet someone who's like, I've run for 20 years and I want to gear up for the New York City Marathon. And then everyone in between. And we haven't even touched on sprinting versus long distance running, right? And so, you have to kind of meet someone where they're at and find out what is their injury history, what is their weekly mileage goals, what would they be happy doing, what is their, if they have an event or a race coming up, how far away are they from that? And then I think just training history, if I didn't say that. So all those things play a huge role in what you're actually going to do with a person in front of you.
For sure.
And so the last thing I was going to say with injuries, what was it? It was, like you said, running is so specific, right? And like you're very specialized. If all you do is run, it's very specific. You're doing the same thing over and over again. And that's where you get some of these overuse injuries is sort of the umbrella term. Your Achilles tendinopathy, your runner's knee, patellofemoral pain syndrome, all these things like basically anterior knee pain or ankle pain. And it's because you're not doing anything else and it's really repetitive in nature. So just breaking that cycle and doing other things so you basically increase your movement variability, or one of my mentors back in grad school, he called it your physiological or orthopedic bandwidth, right? Oh. Like if this is you today, this is kind of your cup that you can fill up with water, and you're asking your body to do more than what it's capable, you're always operating at your maximum. So you're always asking for more that you just don't have. So you're always at that maximum performance. So then you're running into friction and trouble. You have pain, you have plateaus in performance. So if you start to change what you're doing from a training standpoint, you start to do some of the plyos you mentioned, maybe you're lifting weights, Now that bandwidth grows, your physiological or orthopedic bandwidth grows, and what you're trying to do falls underneath that, and then you'll find you're not running into a wall all the time, essentially. So,
For sure.
Yeah.
I think you guys bring up a really good point with training, and that's kind of what I want to go into next. I'm going to kind of bring up these questions and frame them in a way, if I like to know to answer it at all, like I'm not a physical therapist. You guys talk about strength training a lot, plyometrics a lot. For someone who is training for a marathon, what is a good way to program like strength training into their like running training? Should it be something they are starting before they start running? Should it be something they do while they're running, or while they're like getting closer to the marathon date? If you guys have any like perspectives on that.
Yeah, I'd say it's like the PT fancy word that we like to use is periodization, but essentially like what that means is like you have different like time periods. Like if you think about it in terms of like a race, you got like the preseason, you've got kind of like the in season where you're preparing for it, and you got like closer to the race date. So one thing that I think is like a common misconception is that when you're like in season or like training for the race, like you should do like lighter weights, lower reps. But that's actually quite the opposite, because like when you're running, you're like already like doing like a lot of like high volume stuff.
Mm-hmm.
So during the in season, you actually want to shift to like heavier weights, but they're doing fewer reps. So like probably like 5 or 6 reps or less. But then when you're like off season, so say like you're not in that like 12 to 16 week range where you're like really training for the race, that's when you should be trying to do more like hypertrophy type training, which means like muscle building. And in that time, you're trying to do like, you're still trying to do heavier weights, but then like in like the 8 to 12 rep range, like that's been shown to like be more effective with like building up muscle.
I see.
Because like then your body's not going to be like as tired from like training on top of that.
I see.
Of course, you're still going to be running a little bit when you're off season, but it's not quite the volume that you're going to be running like when you're like really like in that race season, you know? So that's definitely like one thing I'd say. Like, and if you're not familiar with like strength training, like definitely either work with a trainer, work with a PT, like work with someone who like has that understanding and can like guide you through that. But yeah, that's like overarching thing I'd say is like higher reps, like when you're like in that preseason, like not in like that race training season, and then like actually like lower reps, but then like maintain that strength, because you want to maintain that max strength and like force output when you're like preparing for that race, 'cause that's going to help you performance wise.
For sure.
Yeah. No, you crushed that. That was awesome. I think a visual or a timeline could even help paint that picture a bit better. Is like, let's use the New York City Marathon as an example. It's usually, I think, the first Sunday of every November.
Right.
And we just had it. It's funny, this time of year is when you get a lot of post-marathon runners coming to the clinic because they ran it in November.
Their feet are all fucked up.
They started having pain around the holidays, but they just put it off because it's holidays. Maybe it'll go away. And then mid to late January, early February is when people start realizing, okay, maybe I should go get this addressed. And then they end up in the clinic. And then you have a bunch of overzealous new runners who are excited to run like a half marathon in the spring. So it's funny being here in New York because there's a very predictable pattern to the running season. So let's take the New York City Marathon as an example. That's November, and it's January now. So what you were saying, right? Your frequency and time spent in the weight room right now should be at the highest it's probably going to be, and your time spent running might be the lowest it's going to be. So if this is, a timeline, lifting's up here, running's down here, and as you approach November, it's actually like an inverse relationship almost. You start to lift a lot less, but to maintain the gains you made early in the year, it's almost like an airplane. Once an airplane takes off, it takes a lot of work for an airplane to take off. And then once it's up there, it's easier to kind of coast and keep it up there. And I didn't make that up. I got that from somewhere. So whoever made that up, I give you credit. I just don't remember the name. But it was a great analogy, and I liked it because, it's in the off season right now, early spring, winter. You're lifting a lot. You might be lifting depending on how much you like being in there, 2 to 5 times a week pretty intensely. And like you said, the volume is high, meaning the amount of sets and reps and the repetitions you're doing is moderate to high. You're building a lot of volume, hypertrophy, which means muscle growth. Maybe you're dipping down into some strength adaptations with that. And then as your mileage picks up, naturally, as you get ready for a marathon, you're going to not be able to allot enough time for the weight room. If you're doing both, you're probably going to be just beat up all the time, and that's not ideal either. So you might lift once or twice a week. Maybe a lot of runners I worked with last year for the marathon, we had them lifting once a week, 6 weeks out. But you're maybe in there 30 minutes, but you're maintaining the gains you made previously, and it's a lot easier to do so.
Now, highlighting more about training, I do want to ask, so for you guys, what would you guys say are some muscle groups that typically people forget to train when in regards to running? Some that come to my mind, like, does upper body matter at this point? Talking about like core stability, what does that look like? I think a lot of times, my brother, he loves marathons. I told him to do strength training. He's just spamming like calf raises and like squats. I'm like, bro. So I think, like, from your standpoint, seeing these injuries, seeing these athletes, what are some muscle groups you guys would like people to focus more on?
I hate this answer, but it really is true. But like you gotta like really strengthen that like your hip musculature, like your glutes and everything. But like with what you were saying about your brother, like always doing squatting, I'd be curious if he's like, is he doing any lunging? Is he doing anything like single leg?
Single leg.
Like he is doing single leg.
Oh no, I'm
okay.
saying he's not. Yeah.
Yeah, because that's like that really works like your whole chain. You know, like you are working on your core stability with that, and you're putting it all together. It's like a lot more specific to running because like when you're running, you're never on 2 feet. You know, like you're always going to be on one leg. So like having that, like like strength and B control, because sometimes people have like really good strength. Like you could like push on their leg and they're strong.
Yeah. But
they might not have like that coordination. So like doing a lot of like single leg stuff, like not just like balancing, but even trying to squat on like one leg, like do calf raises on one leg. That can like really like help you to put all the pieces together with like your core strength, as well as their hip strength as well, you know, putting that all together. But I also like want to add like a little bit of like rotation as well. Like get them working like in like different planes. Like if everything that they're doing is like forward and backwards, they're not adding anything like side to side, even like or like twisting or like going side to side. That's like a big piece that I think is missing too with like their core strength as well as like their hip strength.
Can we just talk about really quick for like people who don't really exist in this like fitness level, what exactly is like core? Like why is our core so important to like these dynamic movements? Because again, running seems to just be a lot of like, you know, legs. Why do we need to build up like the trunk, the core, like the hip stability, and you guys, everything you guys are talking about?
Yeah. The core is often this. People come in often with this narrative that they have a weak core. The way people talk about it, you'd think if they were sitting up in this chair, they just couldn't, you know, if you had a weak core, you couldn't like sit up. You'd be like a baby. You'd just be flaccid kind of. But what happens?
Flaccid is great.
You like that use of that word?
I love that. That was good.
But it is important. Like you should train your core, but I don't think people have weak cores like they think they are. And I don't think that's what's causing a lot of back pain and stuff. That's one narrative that's a whole different subject. But, you know, your core does, embrace and kind of dissipate and transfer forces, which really means if you're doing, say you're throwing a baseball, right? The power is generated from your legs, from the floor, up through your trunk and core, and then exits at your hand. So that's like this really long path, not long, but a path where there is a transfer of force and energy, and then it dissipates through your upper extremity. And that has to go through the central location where your pelvis and your rib cage sit. And then all this musculature in here. And your core is more like an apple core. It's not just like the six pack here in the front.
Apple core.
It's more like 360, right? It's like a core set you got to focus on. So if you're only doing sit-ups, again, leaving a lot of gains on the table, you want to address your back extensors, your lower back, your obliques, more of the apple core. But yeah, that's really why the core is important. Most things you're doing in an athletic context is going to be your legs are working and your arms are working at the same time. So running, you know, your arm swing is important. Throwing something, jumping, really anything in an athletic context, you have to have something here to transfer forces up through your body or down through your body. And if you're just illfully underprepared to do that, you're probably going to not perform well, or maybe you'll have an injury.
For sure.
Yeah.
Couple more. Oh, so because kind of this last point about running, I think we should talk about form. I think, Jaron, you might have a little more experience on this aspect than the two of us. But let's just say someone's struggling with their stride length, like foot contact. I don't know if you guys want to just take pieces of it and talk about it, but we don't need to talk too much about it. But just like for someone who doesn't understand like what running is, like what should they be? What is proper form?
Run club.
Big run club guy.
So, like one theme that we've like hit on is that like people are very like unique in their like body structure and like their like training experience and everything. Like, so there definitely is like no one optimal running form, you know, like, cause like everyone kind of runs like their way. Like lots of people like will focus on like cadence and stuff. Like there was like a school of thought where like 180 cadence was like the golden standard, but that's actually not the case. But one thing that's been shown to be like a really simple change that's been like shown to like have some good results with like improving shock absorption, like decreasing like how much you're going like up and down, and like increasing like how much your knees are bent to, because you don't want to, if you're like really stiff legged, like it's going to be like a lot of force like going straight through the legs. But that change is like by increasing your cadence by like 5 to 10%. Like let me rephrase that. Increasing your self-selected cadence. So like, for example, say like I naturally run at like 160 steps per minute.
Sure.
That's like my like self-selected one. But if I increase that 5 to 10%, that's too much math for me right now. But you like increase it by that amount. Whereas like Andrew's cadence could be like 185. You know, like much
Wait,
higher.
was that one faster than yours?
Yeah.
Okay,
185 steps.
185 is a lot of steps.
185 is more than 160.
Well, Tyreek Hill out here.
I didn't hear the first one.
So like say his like self-selected is 185. Even though he's like already pretty fast, like it could like it's something worth trying to see like, hey, if I like bump my cadence up like that 5 to 10%, like but we'll even backtrack even more. Like I'd say like if you're having issues, like that's when you should be like looking into changes. If everything's working great, like why change it? You know, like
for sure.
Of course, there's like always like you can always look at performance. You can always run faster, but like if you're like injury free, like I would like wouldn't do a whole lot of like tweaking and like changing of like your running form and everything, because like something you're doing is working. You know, so. I know it's like really simple, but like if it ain't broke, don't fix it, you know? So that's like one thing that I've like seen to be like pretty effective with people of like cadence manipulation.
Yeah. Cool. I think one thing that you mentioned, the don't broke kind of fix the thing. As physical therapists, we're trying to kind of look for impairments. So like knee valgus, like are they pronating too much, like when the feet like go inwards and whatnot. But I also want to bring up the aspect of like controlled compensations almost. Like sometimes compensations appear as a result of some injury, but also sometimes they appear as a result to like kind of like go against an injury. So sometimes they're in place for like creating this pain-free like experience. So I think it's like, even though you feel like you run weird or whatnot, maybe this is what's working for you and just leave it at that. You don't have to like conform to like straight knees, like perfect, like doming and all that stuff. And like what, 4-foot contact or something like that.
If anyone's listening who doesn't have a running background or a training background at all, this can be useful. A lot of times when I have a runner come in, they're focused on the short-term kind of sexy stuff. Like I want to have my form checked. Let me finish my thought. They come in, they want to have
they just want that massage, man.
No, they want to know what's the newest gadget or shoe or wearable that's going to optimize their performance and make them feel better. Can you look at my running mechanics? Would you recommend a Hoka versus a Brooks versus a Asics running brand shoe? And that's usually maybe the 1 or 2% that'll fill in the little crack at the top of what actually you want to address. And so you kind of have to, again, communicate well, kind of settle them down. Hey, let's address these other big things first. And the big things would be your running mileage, how like your running history, how long have you ran? How far do you want to be able to run? Do you have a race? Do you want to just be able to go out, you know, recreationally 2 to 3 times a week and run a mile or two? That's a very different story than someone who wants to do sprints to play a sport or run a half marathon or a full marathon.
For sure.
Are they lifting weights? If they're not, then that's, again, so all these things really just managing running mileage, supplementing the strength training or strength training if they're not doing it at all. That's probably going to clean up a lot of these things most of the time before you have to go in and actually look at what the running mechanics looks like and what kind of shoe they're wearing. But usually people, those are the first 2 things they want. And it's really interesting to note that. So, yeah.
Kind of goes back to like the quick fix thing, like a new shoe or like new this or that, like seems like it's like the quick fix.
Totally.
But,
especially like plantar fasciitis. They just want like an insert or like a new shoe.
But again, if you're working with a person who they've run for 20 years, they've run 3 or probably more than 3. They probably run like 4 marathons, 6 half marathons, right? And they can even tell you their split numbers and their PRs in the past. Then you know you're very different context.
Right.
All right. This person's probably seeing another strength coach and doing strength training. So then maybe that's an opportune time to get them on a curved treadmill and check out their running mechanics and get into more of that nuanced weeds with them. But if you did that to a rookie or a beginner, you'd probably be doing them a great disservice. So
for sure. Cool. That was really good, guys.
Thank you.
All right. This last part we're gonna do is kind of quick fire questions from our subscribers and audience. I think it'd be better if we just did like one person each take one. That
right.
way, yeah. Because okay, we're just gonna go for it.
Popcorn,
Okay,
Andrew.
popcorn.
Yeah.
Andrew, how do I know I'm getting scammed at PT?
It's a good question. I don't know if anyone's deliberately scamming you. Well, I mean, maybe. But let's say, I think what this person might be hinting at is what you'll hear referred to in the industry as a physical therapy mill practice, where you go in, you see a PT on day one, and it's one-on-one. They evaluate you, and then they create this plan of care for you. And you're like, awesome, that was cool. And then when you go back, you don't see that same person. There may even be multiple contact points and people coming up to you and helping you. You might look around the room and notice there's like 8 other people there. You're kind of doing the same thing all the time, and you're never actually getting off of a treatment table. They're doing a lot of ice and heat and e-stim, and you have goals that are more advantageous than just kind of laying on a table for an hour 3 times a week. Then you might know, hey, you could be spending your money and time elsewhere. But again, that model needs to exist, and that model does help a lot of people. So I think it should still be very much a thing. And it's a great option for people who are post-operative and pretty limited. So sometimes people reach out to me in my current role, and they just had a surgery, and I'll tell them, hey, you probably would actually benefit from going to this place and getting this type of care for, 6 to 8 weeks, because you're pretty limited in what you can do anyway. So logistics matter. So if they can pay $20 a visit with their copay, it's a network for them somehow with their insurance provider, and they go in and a PT basically just slides their leg up and down and does some stuff to their knee. Let's say in this case they got surgery, then that's probably going to be better for them than if they come and see me and do it out of network
For sure.
at like a higher price point potentially. So that model needs to exist. But I would say, yeah, if you're a person who's having this more gray area pain where you've had back pain for a long time, you want to run a marathon, and then you go in and you're getting that type of care like you had a surgery almost, then that's probably a sign that I wouldn't call you're getting scammed, but you might just not be getting very good care.
Okay, that was good. Jaron, how do I crack my neck?
I'm glad you got this one.
I'd say long story short, don't really try not to. Like when like a PT or like a chiropractor does it, they're putting your neck in like a specific position to try to promote more movement. That's the theory behind it, is that you're trying to promote specific movement. And when you're just kind of cracking your neck on your own, it's like it's not very. There you guys go. You guys are bad examples right now.
That felt so good though.
But like you're just getting like overall more movement, which might not be what's best. Like so, when like someone's like when like a healthcare professional is doing it for you, like it's like a little bit more specific. So I'll leave it at that. I don't have a whole lot more to say about
Good
that.
answer.
I just feel like cracking your neck is really just like release, like the one that we do. You're just releasing like air in between like the discs or something, the joints and stuff. So
I think a big explanation out there now is like if you crack your fingers.
Right.
That's a little, what is it? ASMR, a little accent.
That's good.
There we go. But I think the working theory is it's like, the fluid in the joint being popped. But I think there's a lot of other things probably going on too. Who knows?
A lot of things popping back there.
Yeah. I think it's almost, I know you said one person, but I almost think it's like any other just habit. Like some people fidget, some people scratch their scalp, or it makes them comfortable and feel better. So I swear, people probably start cracking stuff, and it just comforts them on some like low level that they don't even realize. So they do it all the time.
For sure.
But you're probably not actually doing anything to your neck of any significance.
All right. Back to Andrew. How do I fix tech neck? So tech neck is someone who just sits at the desk all day and they just.
Yeah. Okay. So tech neck, or forward head posture, where you're kind of, slumped over all the time. I think it's a question about posture. Yeah. Everyone.
Real quick.
Every time we start talking about posture, everyone kind of gets, I think with this is more along the lines of asking about posture, really. I don't think tech neck is this thing that is actually a medical diagnosis that is treatable. I think it's just more chronic positioning at work, so you kind of are feeling stuck in that pattern and it causes discomfort and pain because you're just not doing anything else. So I would argue that if you had perfect posture, you sat like this constantly at work, you would probably also feel equally tight and uncomfortable as you would if you sat this way. It's more of a getting in and out of positions, changing positions, being very adaptable and having movement variability. So get up and go to the water cooler and chat to a coworker, or stand for a little bit. Kick back and put your feet up sometimes. Sit up normally, slouch a little. It's okay. I think if you're doing more movement than not, you probably will feel better. And I think text neck is a thing that is often separated from just normal postural observations. I think it's all kind of the same umbrella.
For sure. Okay. Jaron, my arm goes numb when I sleep. Do I need to see a chiropractor?
Why am I getting the weird questions, man?
It's not weird.
It's on purpose. Thank you.
I'd say like it depends on every answer is it depends, but I think but then say what it depends on, So it definitely depends on like the consistency and like severity of it. If it's like one of those things where you like wake up, shake your arm a little bit, it goes away, like it's probably not too big of a deal. But if it's one of those things where it's like pretty constant, then definitely like not necessarily like a chiropractor, but definitely go seek like medical care. Because like there's like a couple different like diagnoses that it could be like connected to. Like one it's pretty common, it's called thoracic outlet syndrome, which is just where like some of like the nerves and like vasculature is like being compressed, so that like leads to that like numbness feeling. Like there's like definitely things that like, we're able to do in physical therapy to treat that. But yeah, if it really is like something that's like bothering you, like my rule of thumb that I tell people like is if it's like limiting what you want to be doing during the day, like go get it checked out, go get it treated. Because like why wait and like why let it nag you and like let it keep like restricting you?
For sure.
Yeah. What was the question again?
My arm goes numb when I sleep.
When you sleep, that's what I want to make sure. So I'm gonna be. It's a little silly, but also just to make a bigger picture is. I think it's totally human to have a numb arm when you sleep sometimes. Like I woke up, I'm not kidding, 3 nights ago, and my left arm, it felt like someone else's. I had to move it and get it out of the way. And that happens probably once every 3 months or so. I think it's just a human thing. Sometimes your arm falls asleep.
Yeah, you need to see a doctor, right?
You said chiropractor.
I do think, though, what you're saying is, context matters. So if you're having very predictable patterns and you're noticing this more outside of just sleeping, then it's probably warrants getting it, checked out at some point. But if it's just in the middle of the night every now and then it's probably just being a human.
I would like even ask like, how are you sleeping? Like, are you sleeping on your arm? Because like there's nerves that run through. You're just compressing on some nerves. So
totally. And that's one other thing I have issues with. People will always say, it's probably I slept a certain way. And sure, you can do all you can to set yourself up. Maybe use pillows or bolsters or some type of, I don't know.
Straps.
Yeah, I was going to say like a, but ultimately once you're asleep, you're unconscious. So you're probably going to toss and turn. And I do think how you can sleep can aggravate things in certain people, but it's hard to control for it. Cause what are you really going to do? Unless you have some type of thing that keeps you in place. Like sleep on like an inversion table, like a vampire or something.
Jesus. All right. Back to Andrew. So aside from like being stronger and like, I guess in some cases looking better from a aesthetic standpoint, why should I like do strength training? Like what are some other healthy benefits?
Yeah.
Could be a guy or a girl. Yeah.
Yeah. I think both sexes would like to evade disease and all cause mortality, which really just means, like heart attacks, heart disease, strokes, high blood pressure. All these things can be, what is it? External factors versus internal, or I don't know what the verbiage is.
I think that's right.
Like things you can control versus things you can't. Some of these things are controllable. So yeah, strength training. I always tell people I work with, I try to set an expectation because the vanity part of it, the aesthetics part, and the gym fitness scene can be really discouraging for people, and they don't want to step foot in a gym. So I try to paint more of a broad picture that, hey, that stuff is just maybe a nice byproduct. Sure, you might look good because you're doing it. For a lot of people, that's the goal. But I think if you're going to sustain a good habit of it, having a better understanding of what you're asking is important. And so that's, again, your muscles almost act like a sponge, right? And they kind of like pump and release, and that gets blood circulating, and good things tend to happen when you are strength training in that regard. And then in terms of your musculoskeletal system, you're hanging on to skeletal muscle, which as you age is going to help you stay independent and mobile, meaning your problem when you're 75 isn't going to be, hopefully, how do I get from my couch to my walker to the bathroom, back to my walker, back to my couch. You want your problem when you're 75 to be, I don't know that I can play 5-on-5 full court basketball anymore. Maybe I should play 3-on-3 half court, right? Or can I garden with my friend next door tomorrow? You want those to be your problems that you have to think about, not the other one I mentioned. And so strength training is going to help you hold on to muscle. And then the last thing I'll say is, and it's similar to what I just said, but bone density, especially in females.
Osteoporosis and all that.
Totally. Like that's going to happen if you just kind of go about your life doing nothing ever. So you're actually, when you lift weights, adding stress to the body, to the system, and your body adapts to that. And so your bones, they stay hard, they don't wither. And when you're older, you're not going to, fall and break your hip. And then you could go much more into this, people who break their hips when they're older, really bad things happen after that. And it's a slippery slope. You start to have bad cognition. So all this to say, it is just a very preventative, probably the most preventative thing you could do. And we didn't even touch on the cognition, mental health aspect of things too, which there's research for.
Yeah.
So.
All right. And Jaron, one more question to you, and then we'll kind of wrap up. What is the importance of a dynamic warm-up before activity? And if you even want to just go further and talk about like a static warm-up versus a dynamic warm-up, and I guess like before you run, after you run, all of that stuff.
Sure. I'm a big proponent for doing like a dynamic warm-up beforehand. And then I think static stretching like does have its place. Like I prefer to do it after the workout, just because like at that point your muscles are looser, they're warm, and they'll like be a little bit more responsive to that static stretching, which is like the traditional like hold it for 30 to 45 seconds. But with what you're saying about the dynamic warm up, for people who might not know the difference, like that's more of like the kind of like side shuffles, like doing like some like squats. I think that's really important because it helps to essentially like prime the muscles that you like want to be working. And so when I was in high school and wrestling, our coach would always tell us like, you want to wrestle a match before you like even step foot on the mat. Step foot on the mat. Yeah. Because the reason before that is because like when your body gets like shocked, like you like for like football, if you like get hit or if you like start running, like you don't want to surprise your body, so you want to like do like a really solid warm up. Like it doesn't have to be like to the extent of like wrestling a match before your match and everything.
For sure.
But like you do want to get your muscles working, like get your blood flowing. 'Cause that like helps to like loosen up your joints a little bit. Helps you to like activate the muscles and just like get them moving. So like definitely has a lot of like benefits, like performance wise, as well as like health and like injury, like decreasing the risk of injury.
Yeah, I just feel like we see so many healthy patients who don't stretch before they do stuff, and like stretching could just not stretching. Well, having a good warm up can just go so far in protecting your joints, protecting yourself.
I'll say one last thing on that, like I read Kobe Bryant's book, rest in peace. And one of the big things that he said is that like as he like progressed in his career, like he could start like when he was 18, 19 years old, he could just like show up right before practice and then like get going right away. But then like he like had to adapt as he like got older, like icing, like contrast, like doing like all this stuff, like working with his PT. Like as his career progressed, like he had to like essentially like adapt to his body getting older.
For sure.
And I tell everybody that, like when you're 40, you're not gonna be like moving the same way as when you're 20,
Yeah.
And everybody, like professional athletes, like have to like adapt to that also, So like, why are we any different? So you definitely have to like adjust like what you're doing and help you to like keep up with like the things that you want to be doing,
For sure. All right. Last question to both of you guys. Yeah. Why would I need to see a PT, just like in general?
I can keep it going. So kind of like what Andrew is saying, like I think that exercise classes are great. Like it's like really enjoyable, like showing up, like the person tells you like what to do, but it is like meant for like a group, like that's the role for it. But if you're someone who's like going to those things and it's like too hard or too easy for you, or you're in pain after doing those things, like physical therapy like really helps like address like exactly like where like the impairments are, and then like with going back to like the scam question, like if you're not getting better, like you're getting scammed essentially, you know, like you're not getting like what is like promised from physical therapy.
Right.
So with like therapy, physical therapy at its best is like identifying those like specific limiting factors like to you, and then being able to adjust them and correct them in order to get you to be doing what you're doing. So like physical therapy is, exercise isn't like a one size fit all. Physical therapy is like not a one size fits all, and like someone might not be the best fit for like my clinic, someone might not be the best fit for Andrew's clinic, but they might be the best fit with your clinic, you know? So you do have to like kind of figure out like where like the best relationship is, like, and like find someone that you're like able to work with, and then that they like have an understanding of like what your needs are and like what you want to be doing.
For sure.
And that like individuality is I think what really sets physical therapy apart. It's why it's a career, like why it exists, you know? So
Yeah.
Andrew, anything?
Yeah, last thought I kind of have on this is, let's say for the sake of this conversation, you're one of the people we talked about with more sort of undescribed or uneasy understanding pain that you're having. You've seen other providers and you don't know what's going on. Maybe even a few of them said, yeah, let's say it's back pain, right? We could go in and do some type of minimally invasive surgery for you and fix it. Physical therapist is very unique in terms of what we do, because you spend so much time with people, where when you go see a physician, they might see you. I've been in a physician's office and been seen for maybe less than 5 minutes before, where you're waiting, you're seeing the nurse practitioner maybe, or the physician comes in, it's been under 5 minutes and they're out the door.
Yeah.
So we have a really unique opportunity where we spend an hour with our people, sometimes less, but depending on the setting, that first initial meeting is an hour and they get to just tell you everything. And I think that is really unique, because sometimes when you're kind of rushing it out of other offices, you might not feel heard or understood. And with a physical therapist, we quite literally want to find out, what are you worried about? What can you do? What can you not do? And what do you want to be able to do? And how do we bridge that gap? And am I the person to even do that for you? And if I'm not, where can we get you where the person you should be with is? So I think that's what's unique about what we get to do.
Hell yeah.
all right, Adrian, you got to answer the question too.
Yeah. Why should people see Adrian?
There's not much to say.
Because he's a jolly guy.
I'm just a chill dude. If your doctor's an asshole, come see us.
Yeah.
Why should someone come see a physical therapist? I think there's nothing much to say, but like echoing what you guys, it's like if you have an activity that you're trying to get back to, and like I think it's at the end of the day you have to understand like medicine is a quick fix, but it's not the one fix for all. So your other solution to getting back the life you want, physical therapy, a lot of times can be that answer for you. A lot of times, like what doctors can do is like injections and surgery and whatnot, but that's never a guarantee. Kind of like, it's not a guarantee that's going to fix all your problems. I think part of being a physical therapist is also that therapist term part of it. Like, as much as we are your care providers, we're also kind of like that support role for you. We try to meet you where you are, and our goal will always be for you to like see you at the door, like completely like happy and free, you know? So I think on that, again, like from that standpoint, we do differ from like a physician or like a more of like their primary care providers, right? So, yeah.
Man, I'm sold. Are you accepting new patients?
No, are you accepting new patients?
I'm sold.
Thank you guys for coming. I really appreciate it.
Thanks for having us.
Yeah,
Adrian.
this was
This
fun.
was fun.
Yeah.
PT advocacy.
It's
Woo!
kind of just like hanging out with some mics.
That was the goal, you know.
Yeah.
Do you guys have any like last words for the audience members, or any like nuggets of truth?
Yeah, like I'd say like post grad, like I don't know if any PT students are listening. Like it does change like post grad. Like you went from like playing basketball once a week and like being in class together all the time to like now catching up on a podcast, you know? So it is like cool to see like the transitions and like how things change like after graduation and stuff. And I just wanted to say just like a thank you to like our professors and everything.
Yeah.
Like clinical instructors, mentors and everything. Like you guys know who you are. Like, but like they really did like pour into us and like get us to the place that we are right now.
Yeah.
So big thank you to them. Thank you for having us on the podcast, Adrian.
I wasn't expecting that, Andrew.
Yeah. I would say to the listeners, of which there are many, be proactive with your health, not reactive. You know, take care of yourself. You get one body in this quick lifetime. You live in it. So give yourself the respect it deserves, and take care of yourself however that looks for you, and make it enjoyable and realistic to do all the time. And that's it.
Just to reiterate, this podcast is the collective. Like, we haven't been practicing for too long, and this does not reflect the professors or like our friends and whatnot. It's truly just the three of us just sharing our personal experiences and what it's like to been in the workforce. So, I mean, it's been, I think like it's been very cool seeing how much you guys have also learned in your respective fields. Like, definitely was not from our schooling. So, yeah, it's like cool to get together and just kind of nerd out about what we do. It's always different, like talking to people who work in the same field versus like, I don't know, other healthcare providers, you know?
Definitely.
Yeah.
You know. Cool. All right.
Well, I'd say one more plug. I started physical therapy Instagram at JJ the DPT. Still working on posting things, but if you gave me a follow, that'd be a big help.
For sure. I want to have their socials in the comment sections if you want yours.
Of course.
I'm also going to have your workplaces if you guys are comfortable. I think if you guys have any like ortho stuff related, back pain, literally anything, like these two are some of the best like ortho PTs. I fully trust to like take care of you guys. So
Thanks.
Appreciate that. We also work with people outside of New York City. So reach out.
Yeah, definitely. Thank you guys for watching. Thank you for the subscribes and the likes. It really helps the channel whenever you guys subscribe, and the views and everything and the comments. So really appreciate you guys. And with that, TTY.
You said, and for now, that's what you're supposed to say.
No, with that.
Oh, my bad. Just trying to
I think we did it. I think we should leave it like that.
Leave it like that.
TTYL.
All right. TTYL,
Talk
guys.
to you later.